Good morning, everyone.
Good morning, Madhuri.
Hi, everyone. Good morning. I hope you all had a pleasant New Year. Thank you for taking time to join today's session. We will allow few more minutes for additional participants to join the call. We will start the session by 9 o'clock. Allow us some time. Srinath, is the background noise from your side?
కొంచెం సేపు సైలెంట్ ఉండాలా.
Adi, we started the broadcast. We are live, Adi.
Yeah, Madhuri, it's not my
Fine.
voice.
Fine.
షూర్
Fine.
షూర్ మాధురి.
Okay, Adi. We are live. We will start the session by 9 o'clock, Adi. Okay, in the meantime, by show of your hands, how many of you work with heart failure DRGs, whether it is in clinical, coding, or revenue integrity role? And how many of you have encountered documentation queries related to heart failure specifically? Can you raise your hands? Great. We see good response here. So I hope you all are waiting to get the clear info about heart failure. That is good, guys. Especially during weekend, everyone joined the call. It is great. Before we introduce our speaker, I will now hand over to Adi for an overview of the chapter offices. Adi, shall we start the meeting? If you are ready,
Yes,
we
Madhuri.
can start with the
Yes.
chapter officers intro. Then we
Yes.
will start the section.
Yes.
Thank you, Adi. Handing over to you.
Thank you, and good morning, everyone, and wish you all a very happy New Year. Hope everybody had a great celebrations for the New Year and getting ready for your Pongal celebrations. And glad that everybody is taking time during the holiday season to get another amazing learning session by the Hyderabad local chapter. I could still see that there are few more people joining in. And before we journey with us and who's been a part of our journey with the Hyderabad local chapter with an amazing learning sessions that what we have brought in and looking forward for another 12 more great learning sessions including today's. Please feel free to reach out to us for any of the topic or any learning session that you're looking forward to. We will definitely make sure we will accommodate the same. And we would like to bring in the education sessions that is useful for everybody in day-to-day life. Any guidance that you would seek, please reach out. And having said that, would like to take a moment to introduce our new chapter officers for 2026. So, as you know, all the other chapter officers remain same. Me, Adi Lakshmi Sankara, serving as the president of Hyderabad local chapter, and I have Harish Chunduri, who's the treasurer for the local chapter officer. And I have Srinivas Reddy, who's our vice president, Hyderabad local chapter. We have Basha, who's our member development officer for Hyderabad local chapter. And we have a new officer, Mr. Guru Prasad, as a secretary for the new officer for the Hyderabad local chapter. With all said, that Mr. Fani Goli Sai Fani, who was our membership development officer for 2025, I would like to take a moment to thank him for his tremendous support over the 2025. And I wish him all the best. And he decided to move on. So we have another opportunity that has gone to Mr. Guru Prasad. And looking forward for another great sessions again for 2026. Thank you so much. Funny on your
Adi,
efforts for
we
2025, and
lost you.
that's
Your
greatly
voice is
appreciable.
breaking
So,
in
guys,
between.
we will all the local chapter officer things. Am I clear now?
Yeah, you are clear now. Yes,
Okay.
Adi.
So, please, we will publish all the chapter officer details. Keep yourself updated on the updated officers for 2026. Keep us posted on any of the topic that you would like to learn and listen from us in 2026 at any given point of time. We will definitely consider all the topics and suggestions that comes from you all, and we will try to accommodate that. Having said that, introducing all the new officers, thank you note to Mr. Golifani. I would like to hand it over to Madhuri to take over for today's learning session, another amazing learning session on the heart failure. Looking forward for a great learning session today. Wish you all a very happy new year and a happy
Thank you,
Pongal
Adi.
all of you.
Thank you
Over
so
to
much
you,
for the
Madhuri.
chapter officers info. Thank you, Adi. Thank you for your time. Let us like no further delay to help and clarify the questions and queries related to heart failure. Let me introduce our speaker for today's session. He is Hari Ubaleshu. He has over a decade of experience across US healthcare operations, revenue integrity, and payment integrity, with deep expertise in inpatient DRG audits, coding validation, denial management, and also he has experience in claims adjudication. Currently, he is serving as a revenue integrity manager in Kentucky, and he plays a key role in driving complaints and optimizing reimbursement accuracy, and also supports value-based core initiatives. Without further delay, let me welcome Hari to the session. Hari, over to you. The stage is yours.
Thank you, Madhuri. Uh, Good morning, all. Am I audible?
Yes, Hari, you are audible. You can share the screen.
Good morning, all. It's a privilege to speak to such a diverse and experienced group of AAPC Hyderabad local chapter. And today I would like to share some key insights on heart failure, which is one of the most frequently encountered conditions in patient settings. Like today we are going, today's session objectives are like we are going to learn the heart failure and its problem statement.
If you are
Prior to
sharing your
going to the
screen, your
heart
screen
failure
is not visible to us. Can you reshare it again?
Okay.
Please share your screen.
It's not, yes, 1 minute, 1 minute.
Okay.
Are you able to see my screen?
Yes, Shahari. Yeah, it is visible now. You can go ahead. Thank you.
Today's session's objectives are like we are going to learn the heart failure and it's in a problem statement. Prior to going to that, I would like to discuss of anatomy and heart and cardiovascular system for a short while. Then followed by an etiology of the heart failure and then types of heart failure and based on the occurrence, site, and all, and its different diagnostic modalities, and its clinical validation, and some physician query opportunities, and that will at the end we'll see the coding guidance for a heart failure. Then when it comes to the cardiovascular system, then otherwise it will be made up of your heart and blood vessels. Then today's session concentration is mainly heart and its related failure. Like in a heart can be compared with a house. Then how we can easily remember the heart and all, like in its anatomy and all. I will try to explain at the end of this anatomical discussion. The heart is a fist-sized organ that pumps blood throughout the body. With that help of that pumping, our body is going to get all nutrients and oxygen, whichever required to the each and every cell. It contains 4 chambers made up of muscles and powered by electrical impulses. Then it's located in mediastinum in thoracic cavity. It's the parts of the heart, including walls, chambers, valves, blood vessels, and electrical conduction system. Walls are like it's made up of muscles. Especially there are 3 layers of walls in the heart, like in endocardium, which is an innermost layer. Then the myocardium is a muscular middle layer. And the epicardium is in a protective outer layer. Then valves can be classified into 2 broad categories. This works as in a doors, like an atrioventricular valves and then semilunar valves. Atrioventricular valves can be further. There's 2 types, like a tricuspid valves, which is from right, which allows blood from right atrium to right ventricle. Then mitral valve, which allows blood from left atrium to left ventricle. Then semilunar valves are 2 types. Aortic valves, which opens between the right ventricle, left ventricle to aorta, and then pulmonary valves from the right ventricle to pulmonary circulations, pulmonary arteries. Then heart chambers. These chambers are 4 chambers, 2 on right side and 2 on left side. On right side there will be right atrium and right ventricle. On left side there will be left atrium and left ventricle. Then blood we need to understand how, to understand the heart failure in better manner, we need to understand how blood flows within the heart. Then usually right ventricle to it enters into the pulmonary circulation, where from right ventricle the blood goes to the pulmonary artery via pulmonary arteries to lung, where that oxygenation deoxygenation happens. Then it enters into the left atrium with the help of pulmonary veins. From left atrium to left ventricle, from left ventricle to arch of aorta, it enters into the systemic circulation. This is the any problems which can cause a flow of this blood and its pressures can lead to failure. Then blood vessels are mainly we need to discuss about arteries, veins, and capillaries. Then again, heart itself is going to be supplied within three major arteries, like two main arteries, which is left coronary artery and right coronary artery. Then left coronary artery is further divided into circumflex artery and the anterior descending arteries. Left circumflex artery supplies the blood to the left atrium and side and back of the left ventricle. The left anterior descending artery is going to supply blood to the front and bottom of the left ventricle. Then again, right common coronary artery supplies blood to the right atrium, right ventricle, and bottom portion of the left ventricle and septum. This electrical conduction system, which controls the heart rate and rhythm. Then there is two mainly we need to discuss about sinoatrial node, where that impulses will start. Then it travels to AV node, atrioventricular node. From there to bundles, like a left bundle branch, right bundle branch, and Purkinje fibers. All together, we need to consider it as an electrical conduction system. Then, when it comes to anatomy of the heart, while before closing that anatomy, that heart can be easily remember the anatomy and all. It can be compared with a house. House generally have walls and interior septums, like an inner walls. Then again, this valves can be compared with the doors, which allows outflow in inflow. But here it's a one-way direction only. Then when it comes to the arteries, and arteries can be compared with the plumbing system of a house. Then electrical conduction system, like in a bundle of AV nodes, SCA nodes, or can be compared with wiring of the electrical wiring for a house. This is the way we need to easily remember of the heart and everything. Any problems which can cause these four, like a major parts of the heart, then the failure is going to be inevitable. Then, before going to heart failure proper discussions, I would like to introduce some hypertension and hypertension related diseases. Especially in these diseases, we are going to discuss about hypertension, hypertensive heart diseases, hypertensive chronic kidney diseases, and hypertensive heart and chronic kidney diseases. General gold standard blood pressure measurement is 120/80. If any person which are having blood pressure of greater than 120/80 can be called as an hypertension. It will be like there is a predisposing factors like old age, genetics, and being obese, and physically inactivity, and consumption of high salt diet and alcohol. These are the common factors for the development of the hypertension. Then I don't want to spend much time on this hypertension. Then directly we will go to ICD-10 guidance for coding of this hypertension and hypertension related disorders. Then when it comes to the hypertensive heart diseases, usually hypertensive heart diseases are classified in the categories of I50 and I51.4 to I51.9. Why? Because these are the conditions which commonly occurs with the hypertension. Whenever all these conditions are listed within a hypertension, then we can consider them hypertension, heart failure have many other predisposing factors and etiological factors. Since I-50 have a instructional note code first underlying condition, we need to review the medical record to identify the appropriate underlying condition for heart failure. It may not be always hypertension. So we need to identify appropriate etiological factors which was documented in the medical record and assign that underlying cause first, then followed by I-50 category code. Then hypertensive chronic kidney diseases generally can be classified as an arterial or nephrosclerosis, which has been caused by a long-standing hypertension which was uncontrolled or maltreated hypertension cases leads to chronic kidney diseases. Then generally, whenever patient having hypertension which was not treated on timely basis or which was uncontrolled, then it leads to the intimal thickening of the arteries and arterioles of the kidney or renal system, which can reduces the glomerular filtration, and finally it reaches to severe nephrosclerosis. It leads to ischemia of the kidneys and leads to infarction and scar tissue formation in the renal system, which can cause the progression of the chronic kidney diseases. Then most of the times chronic kidney diseases are hypertensive chronic kidney diseases has to be coded to I-12 category in ICD-10-CM. Generally, I-12, when it comes to whenever physician documented hypertension and chronic kidney diseases together, we can assume a causal relationship and we can code directly from the I-12 category. Not like in a heart failure, hypertensive heart diseases, like in a heart failure. For heart failure, physician has to document a causal relationship. We need to, like while reviewing a medical record, we need to hypertensive heart failure or not. You may come across like why I'm specifying this in like an etiology of the heart failure, you may understand very clearly. Then whenever patient having chronic kidney diseases, along with an I-12 category, we need to assign a code from N18 category. Then when we need to consider the chronic kidney disease as a hypertensive chronic kidney disease, then whatever the condition which was documented by the physician, if they are fitting into N18 category, N18 category codes, then all those conditions can be presumed as in hypertensive chronic kidney diseases, and we need to code them from particular I-12 category series and N18 category series codes. Then suppose if a patient having acute renal failure also, then we need to assign an N17.9 code, and the sequence will be depending on circumstances of admission. Then another category is hypertensive heart and chronic kidney diseases. So whenever I-13 is upcoding, we are not supposed to code separately from I-10, I-11 and I-12. Then when it comes to the congestive heart failure, simple. Whenever we need to understand any organ failure, then we need to understand thoroughly what is the function of physiological function of the particular organ. When it comes to heart failure, if you understand the physiology of the heart and heart functions, then you can easily understand the heart failure. When layman terminologies, organ failure means whenever the organ fails to conduct its proper functions, then it leads to failure. Slowly impairment that can lead to failure. In that way, we need to understand the heart failure also. Heart failure occurs when there is a structural or functional heart problems that prevents adequate oxygen delivery to the body tissues. Then all those conditions we need to identify appropriately and raise a query if required. Then symptoms are often non-specific and may appear gradually. which is because in early stages of heart failure, which is very silent, there would be no signs and symptoms. But you need to, while reviewing a medical record, you need to refer the different areas of the medical record, what we are going to discuss. If you need any support, raise a like any clarity, raise a physician queries and take his clarification on the particular part and code it appropriately. Then heart failure severity can be classified by, there are many different classifications. I brought but two classifications here. One is American Cardiology, College of Cardiology or American Heart Association, which was based on the structural heart diseases and progression of the disease. Then NYHA classification, which is based on the activity tolerance of the heart. Based on these two categories, that heart failure severity can be heart failure is progressively worsening condition and often silent in early stages. It significantly reduces the quality of life, limiting the physical activity of the patient or person and contributing to emotional and psychological stress. Then when it comes to the definitions, a classical definition of the heart failure can be defined as a abnormality of the cardiac structure or function leading to failure of the heart to deliver oxygen at the rate of commensurate with the requirements of metabolizing tissues despite normal filling pressures. That means though the heart having either impaired filling pressures or not, either having a normal filling pressures also, if the heart is unable to pump the blood whichever required to the bodies to handle all the routine metabolic activities, in that cases that can be defined as a heart failure. Then heart failure can be classified in different ways based on the function. Especially heart function can be measured with the EF. EF stands for ejection fraction. Then it will be measured in the you can identify it in echocardiogram. By reviewing the echocardiogram report, you can find the ejection fraction values. Then based on the ejection fraction, heart failure can be classified into, whenever it is reduced its ejection fraction, it can be called as a reduced ejection heart failure with reduced ejection fraction, where ejection fraction will be less than 40%. Then if normal ejection fraction was there, but still it can be classified as in a heart failure where it's a diastolic heart failure. If a ejection fraction is mildly reduced, like a 40 to 49%, this can be called as in a heart failure with moderately or mildly reduced ejection fraction. Then based on the onset or progression of the disease, it can be classified as either acute, subacute or chronic, or worsening. Worsening can be say it as, sometimes physicians may document it as a decompensated heart failure or acute and chronic heart failures like that. Then based on the location, heart failure can be classified into right, left and combined heart failure. We'll see one by one how to identify them in the medical record based on the physician documentation. Okay. When it comes to the etiology of heart failure, these are the commonest etiological factors which can contribute in the development of the heart failure. In that contributing factors, most common conditions are myocardial diseases, like coronary artery diseases, hypertension, any type of cardiomyopathies, either restrictive cardiomyopathy or hypertrophic cardiomyopathies. All cardiomyopathy can land into a patient into a heart failure. Then endocardial diseases like with and without hypereosinophilia and endocardial fibroelastosis and some amyloid, all those conditions comes under this particular endocardial diseases. Then arrhythmias like both atrial and ventricular tachyarrhythmias and bradyarrhythmias, sinus node dysfunctions, all finally lead to heart failure. Those are the causes of heart failure. Then some congenital heart diseases, then volume overload, like if a patient having renal failure, that is one of the most commonest cause of renal, like in a volume overload, lead to pulmonary edema where then patient landed into heart failure. Then another reason for volume overload is whenever patient was admitted to the hospital, then rushing is like an administration of excessive IV fluids lead to volume overload that can land into heart failure again. Then again, high output states can be classified into like in causes of high output states, like anemia, where patient having severe anemia, they that diseases, constrictive pericarditis and pericardial effusions are the commonest causes which can lead to heart failure. Then valvular diseases, which we say it is a dose for the blood flow in the heart. Whenever there is an abnormality, then obviously there will be a heart failure. Based on this slide, you need to identify. Hypertension is a one cause in this myocardial diseases. Then where if a physician documented hypertension and heart failure and directly it's related to heart failure, then only we need to consider it as a hypertensive heart failure. Though patient having hypertension and heart failure reason is any one of these other than heart failure, we are not supposed to code it from I11 series code. Commonly, common findings in adults is like some poisoning cases. Poisoning cases that leads to alveolar pulmonary edema that leads to heart failure. Those cases are not supposed to code from I11 series code. Then we'll take from anatomical involvement of the heart. Whenever left heart failure is, we can say it's whenever the left ventricle is enabled to pump the blood effectively, that can be called as a left heart failure. It will be classified into either diastolic heart failure, systolic heart failure, or combined systolic and diastolic heart failure. We know systolic heart failure means it's a heart failure with reduced ejection fraction, where ejection fraction will be less than 40%. Then it causes, that's due to inability of the left ventricle to contract effectively. That means whenever left ventricle contracts, that blood is going to be pumped out into the systemic circulation via arch of aorta. Then when this left ventricle is unable to pump effectively, some of the blood is stay in the left ventricle itself, and some of the blood enters into the systemic circulation, which may not be sufficient. Like an inability of the contraction leads to the reduced function. That's why it's called systolic heart failures are going to be called as heart failures with reduced ejection fraction, where if you review that echo reports, there physicians, they used to document clearly like AF will be either less than 40%, and systolic dysfunction also physicians, they used to document in the EF. Based on that, you can code it as a systolic heart failure. Then again, when it comes to the diastolic heart failure, where the LV left ventricle is unable to relax properly to collect the blood, or left ventricle having the limitations to filling of the blood due to any reason, like a valvular abnormalities or restricted cardiomyopathy, like in a left ventricle was like in a thickness, the increased thickness. Whenever thickness increases, the cavity is going to be reduced. Then all these causes leads to diastolic heart failures. Then in that case, appropriately normal, but because of the relaxation, limitations in relaxation, blood is not going to be fully collected, and that though the systole is performing very well, that enough amount of blood is not going to enter into systemic circulation. That's why these type of heart failures are going to be called as diastolic heart failures, where physicians used to document either diastolic heart failure or heart failure with a preserved ejection fraction. Then when it comes to the combined, both are quite different, quite opposite opposite when related to function. Where in a systolic heart failure, ejection fraction is going to be reduced, where diastolic heart failure, whereas in diastolic failure, ejection fraction is preserved. Then when can we call as a combined systolic and diastolic heart failure? How to identify it while reviewing the echo report. Then in combined heart failure, systolic and diastolic heart failure, generally left ventricle having both the problems, like it may not relax properly and it may not eject the blood properly. So it's going to be called as a combined systolic and diastolic heart failure. In these cases, the only blindly we need to remember, in combined systolic heart failures, patients have reduced ejection fraction. And when you read about the left ventricle description, physicians, they used to document a diastolic dysfunction, grade 1, grade 2, grade 3 diastolic dysfunction, like that. Whenever echo is an evident for reduced ejection fraction and a diastolic dysfunction, then those conditions are going to be classified into combined systolic and diastolic heart failures. Then when it comes to the right heart failures, the most common causes of right heart failures are having the left heart failure. Left heart failure lead to right heart failures. Then it causes venous congestion due to impaired right ventricular pumping. Then key symptoms include leg and ankle swellings, abdominal swelling, GI tract congestion, and liver congestion, which may lead to ascites. Also, basing on anatomical involvement, there's another type is a biventricular heart failure, where patients will have both left and right heart failure signs and symptoms, and both left ventricle and right ventricle involved in these cases. Then when it comes to the signs and symptoms of the heart failure, dyspnea is the hallmark of the heart failure, the most commonest finding. Then these signs and symptoms, whatever we are going to be discussed, it's going to be shared by many other. That means many other diseases having the same symptomatology, like both involvement of lung and heart diseases will have the same set of signs and symptoms. That maybe varies one on here and there. Dyspnea, it's one of the commonest condition in both pulmonary diseases and many cardiac diseases. Then raised jugular venous pressure. Usually physicians, they used to document it as in a JVP. You can find it in physical examination part. Then peripheral edema. Most probably it is going to be documented as a ankle edema or lower extremity edema. This also you can find it on physical examination. Palpable liver. This also you can find in physical examination part. Basal crepitations. You can find it on physical examination of respiratory system. Then tachycardia. And then third heart sound. Then orthopnea. Orthopnea is a clinical symptom. It's not a sign. Where it's a sign and symptom. Like a patient is unable to lying on back properly. Whenever he lies on his back, then he develops a dyspnea. Then again, paroxysmal nocturnal dyspnea, chest pain. These are the commonest signs and symptoms of the heart failure. Then common diagnostic modalities for heart failure are some laboratory tests and imaging studies. Based on that, physicians coding or clinical validation and DRG validation purpose, you need to know the laboratory modalities and what is the significance of the laboratory test when we need to say it as a patient having a heart failure. Generally, common laboratory investigations are calcium and magnesium levels to rule out doses of diuretics and other causes of arrhythmias. Then complete blood count to identify the anemia. Then liver function test to identify the liver congestion and volume overload. Then renal function tests to identify the renal causes of heart failure, like overload and all. Then serum electrolytes to identify the electrolyte imbalances. Sometimes electrolyte imbalances leads to changes in ECG. That means we are not supposed to confuse the causes of heart failure, like one of the causes like arrhythmias. Then again, thyroid to identify the thyrotoxicosis and all. Then urine analysis to identify the renal causes. Then chest imaging to identify the pulmonary involvement. Why? Because there is one condition which is both cardiac and pulmonary conditions, that is nothing but pulmonary edema. Pulmonary edema can be classified into two types. One is cardiogenic pulmonary edema, another one is non-cardiogenic pulmonary edema. When cardiogenic pulmonary edema, then when physician documented heart failure, we are not supposed to code a separate code for pulmonary edema. If it is documented as a non-cardiogenic pulmonary edema, we need to code it from J series codes, like poisonings and some other commonest pulmonary infections lead to non-cardiogenic pulmonary edema. Then again, ECG to identify the heart failure etiologies and abnormal arrhythmias and all. Okay, these are the commonest investigations, but there is no specific investigations listed in this slide to identify the heart failure. The next slide explains the specific diagnostic investigations which requires to demarcate that heart failure from other conditions. This is the chest imaging. In chest imaging, either it may be CT chest or chest X-ray, you can find cardiomegaly, either pleural edema or alveolar edema or bat swing sign. These are the commonest findings you need to identify in the medical record and chest imaging. Then echocardiography. Echocardiography is going to identify and quantify the left ventricle and its function. Then it's a structure also. Either left ventricle is normal in size and its function and all. Then EF, both you can identify either it's a reduced or preserved. By that you can identify it's a quality of the heart failure, whether it is a systolic or diastolic heart failures are combined. As well as it can examine the causes of the heart failure such as valvular abnormalities also. These are the significance of echocardiography. 100% mandatory. As a coder or a validator, we need to review that echocardiography to identify the quality of the heart failure and quantity of the ejection fraction. Then again, blood investigations like a BNP and NT-proBNP. These are the more specific investigations to demarcate and to differentiate the heart failure or dyspnea from cardiac reasons to non-cardiac reasons. Again, this BNP and BNP will elevate in many other conditions. We'll discuss it at validation part and what is the significance of BNP. When should we consider it as a heart failure and when should be it is not a non-heart failure cases and all. Then differential diagnosis part, when it comes to differential diagnosis, physicians might document all these conditions in the medical record at the HNP level or at the initial days of hospitalization. You need to identify appropriate condition and code it appropriately. Then suppose if you take one sign and symptom of the heart failure like a decreased exercise tolerance or fatigue, which can be commonest in myocardial ischemia, the myocardial MI, and pulmonary diseases. COPD. When it comes to fluid overload, it may be present in venous thrombosis or venous insufficiency, renal sodium retentions, then drug adverse effects, and cirrhosis of liver. Then when it comes to cardiac anomalies, then maybe like a pericardial diseases, restrictive and hypertrophic cardiomyopathies, severe hypertensions, then acute coronary syndromes with pulmonary edema. Then when it takes a shortness of breath, it is the commonest finding in both MI, heart failure, pulmonary disease, even like a pneumonia, COPD, and other pulmonary diseases, and physical deconditioning also. Based on signs and symptoms, what are the parameters need to be taken to identify that the particular patient having a heart failure. This is we need to learn while reviewing the medical records. Then when it comes to the treatment part, main treatment focus of the treatment is to prevent the heart failures, to control the predisposing factors like heart failures and hypertension and some other conditions is whatever we discuss. We need to prevent and progress those diseases, and we can prevent the heart failure also. Then usually blood pressure has to be maintained less than 120/80. Then like whenever patient having greater than like a blood pressure more than 140, then there's having a great greater incidence of heart failures and all. Then goals of treatment to improve survival and quality of life, to reduce the hospital length of stay on heart failure readmissions, then decrease the morbidity and to prevent end organ damage, then prevent the progression and symptoms of heart failure in asymptomatic status. Then categories of heart failure treatment can be classified into non-pharmacological treatment, okay, based on diet, sodium restrictions, and lifestyle modifications. When it comes to the pharmacological therapy, then GDMT, ACE inhibitors, beta blockers, all these comes under diuretics, all these comes under pharmacological therapy. Then devices will be like non-surgical devices like ICD, CRT placements, mechanical circulatory support, all comes under non-surgical measurements. Then like revascularizations, valve interventions, and advanced heart therapies, heart failure therapies comes under invasive therapies. We'll see one by one. Then pharmacological therapy, these are the drugs which can be used for prevention of the heart failure and treatment of the heart failure, mainly ACE inhibitors and beta blockers, and some nitrates and hydrolysine. Then again aspirin, statin, ivabradine, sodium glucose contraceptive co-transporter. Then again continuous intravenous inotropes. All these are going to be used based on the case. Like preconditions for device therapies are like patients must receive either ACE inhibitors and beta blockers for greater than 3 months. Then reassesses LV ejection fraction after therapy. If EF is less than 35%, consider to refer for this device therapies. Why we need to know this? Like in a few profiles working in denials, where they are going to be appeal their denial. Then maybe patient received any device therapy and which was not documented in the properly in the indications for device therapy in medical record, then that claim is going to be denied. To write an appeals appropriately, we need to know the indications. We need to find out these indications, either patient is meeting for the medical necessity of the device therapy or not. We need to find and we need to code them. During in appeal letters, they need to implement it. Then implantable cardioverter defibrillator, its purpose is primarily to prevention of sudden cardiac death. Then as per American College of Cardiology and American Heart Association guidelines, these are the guidelines. I think for coding level, we are not going to review all those things. These are the guidelines for cardiac resynchronization therapy. Then again, invasive therapies include like cardiac revascularization, like CABG, PCI, angioplasties comes under this particular treatment of heart failures. Not only for myocardial infarctions, they can be treated for heart failure also. Then surgical therapies is like in a heart transplantation, ventricular assist devices, and surgical ventricular restorations. We'll see coding part only for them, in spite of looking for denials and appeals. Then when it comes to the heart failure validation, then this diagram is going to help you very well, like in which cases can be a right-sided heart failure, which cases can be a left heart failures. Then right heart failure signs and symptoms include which can cause we discussed, right heart failure is due to an inability of the left ventricle either to relax or contract, then which can cause leading of a congestion of the pulmonary circulation, will lead to a peripheral tissues, pulmonary circulations along with the peripheral tissues. Then it leads to a dependent edema, especially in ankles, then GI tract congestion and hepatic congestion. GI tract condition leads to anorexia, GI disorders and ascites and all. Then liver congestion also leads to hepatic impairment along with ascites and all. Then when it comes to the left heart failure, mainly heart failure means focusing on left heart failure. Then left heart failure due to impairment of the left ventricle, either to relax or to contract. Then it leads generally, since body tissue is not getting the proper amount of blood and nutrients along with the nutrients and oxygen, these are the commonest problems is going to be happen. Decreased cardiac output, one reason, and the pulmonary congestion. Then decreased cardiac output leads to activity intolerance and signs of decreased tissue perfusion. Then pulmonary congestion leads to increased impaired gas exchanges, which leads to cyanosis and signs of hypoxia. Then again, pulmonary edema leads to orthopnea along with the cough and then frothy sputums, then paroxysmal nocturnal dyspnea. These are the pathophysiology and signs and symptoms which leads to the heart failure, why they're causing these particular signs and symptoms. Then when it comes to the classifications, most of the physicians, they are going to classify the heart failure with NYHA. NYHA stands for New York Heart Association. It can exercise intolerance. Based on the exercise intolerance, NYHA classified heart failure into 4 stages. In class 1, there will be no limitation of the physical activity. Then patient can, a person can conduct, do ordinary physical activities without any limitations or causing any symptoms. This is a totally asymptomatic status. Then when it turns to class 2, then patient will have slight limitations of physical activity, like when he do some exercises and all, he may have limitations like stopping with due to any dyspnea or some sort of physical limitations, signs and symptoms. Then usually patient is comfortable at rest. Whenever he start working after certain limitation, then he is going to develop signs and symptoms. Then when it turns to class 3, then it's a marked limitation on physical activity. Then comfortable at rest, but less than the ordinary activities. We ask the patient to walk for 6-minute walk test. Based on that, they are going to classify these classifications. Then again, class 4, where the patient having severe limitation even on rest also. The simple, a small physical activity can cause discomfort to this patient. This is a class 4, where it is an advanced heart failure. Then another classification which used to progression of the disease, that is American Cardiology, American College of Cardiology or American Heart Association. It's in a chart itself, very big one, and for us as a coders, it's not required to know. That's why I didn't bring it here. Then there is another classification, that is a CLIPS classification. CLIPS classification usually used to identify the risk of developing heart failures in the settings of myocardial infarctions. Since myocardial infarction is one of the most commonest causes of heart failure, where when 90% of patients who landed into myocardial infarction, which was not treated on timely basis. Because of the infarction, the ventricles are going to be damaged, which can lead to heart failure. Then this classification also is very similar to NYHA classification, where they're defined as a classes. Here they defined it as in stages. That is only the difference. Stage 1, there is no heart failure, no clinical signs of cardiac decompensation. Then when stage 2, heart failure, diagnostic criteria include rails, S3 galloprhythms, and pulmonary venous hypertension. Then pulmonary congestion with the wet rails in the lower half of the lung fields. Whenever patient have these signs and symptoms, they are going to be labeled as stage 2. Then stage 3 is a severe heart failure, where patient have frank pulmonary edema with rails throughout the lung fields. Usually on physical examination, lung fields are going to be classified into basal, apical, like that. In these cases, stage 3, all the lung fields having the rails. Then again, stage 4, it's patient landed into cardiogenic shock. Signs including hypotension, where systolic blood pressure will be less than 90 mmHg, and an evidence of peripheral vasoconstriction such as oliguria, cyanosis, diaphoresis, and all. This is the CLIPS classification. Even though for coders or in a clinical validation areas also, this CLIPS classification are not using, because they identify the disease progression by staging itself. Next classification is the Framingham criteria. It's going to be called as Framingham clinical criteria. Based on the signs and symptoms, criteria was defined to diagnose a patient. This is the most widely used criteria to formulate the diagnosis of heart failure. Why? Because when you observe the ICD-10 classification, we'll discuss about in terms of coding only. When you observe the ICD-10 classification of heart failure, then heart failure is classified into systolic, diastolic, and combined. Each again is divided into acute, chronic, and acute and chronic. Then when we need to consider it as if you use an NYHA classification, ACA classification, or CLIPS classification, it's very difficult to identify a patient or formulate a patient's diagnosis with either it is an acute heart failure or it is a chronic heart failure. It's a very difficult. So that's why it was Framingham criteria. Framingham was defined a criteria based on a clinical signs and symptoms. We'll try to understand this. This is only the criteria which was using to validate a heart failure in cases of clinical settings, like in a coding and clinical validation, DRG validation settings. Whenever patients is not meeting this criteria, then straightforward your code is going to be denied. Especially acute conditions, acute and chronic conditions, because these are MCCs. Then this heart failure signs and symptoms are classified into two criteria and minor criteria. Patients should also have a predisposing factors of like an etiological factors which can contribute into heart failure. Then to diagnose a patient according to this criteria, to diagnose a patient with a heart failure, patient has to meet either two major criteria or one major plus two minor criteria. Then only it's going to be classified it as a heart failure and going to be approval. Otherwise, your code is going to be denied, especially acute and chronic conditions. Then what is the major and minor criteria? These are the major and minor criteria which was highlighted one with colors. Those findings will be easily identified in many cases. Which was not identified, you may get them very rarely in medical records. Then we'll see what is the major criteria. Major criteria is classified with the signs and symptoms of paroxysmal nocturnal dyspnea. Usually physicians, they may document with the full title, full description, or they may document as a PND, paroxysmal nocturnal dyspnea. Then neck vein distension. Some physicians, they may document it as a jugular venous distension also, or JVD. Then weight loss of 4.5 kgs in 5 days in response to diuretic therapy. Whenever heart failure is there, that too in acute conditions, they will start IV diuretics. When IV diuretics was initiated, within like in a first 5 days to 7 days, generally patients, they used to reduce the 4.5 kgs of weight by flushing out the excessive accumulated fluid in the body. Then again, patient rails, then acute pulmonary edema or alveolar edema. Some physicians may document it as an alveolar edema also. Then again, hepatojugular reflex, S3 galloprhythm or S3 heart sound. Then radiographic cardiomegaly. When you take it X-ray or some imaging, CT image, CT chest, you can find cardiomegaly. Then rarely identifiable findings are increased central venous pressure that should be greater than 10-16 centimeters of water, and circulation time greater than 25 seconds, and pulmonary edema, visceral congestion, or cardiomegaly on autopsy and postmortem report. These are the major criteria. To diagnose a patient with heart failure, patient should satisfy any two major criteria. Then we can say it as a heart failure along with other parameters. We'll discuss those things. Then minor criteria include nocturnal cough, dyspnea and exertion, decreased in vital capacity by 1/3, maximum volume overload, then pleural effusions, tachycardia, hepatomegaly, bilateral ankle edema. In this, patient should satisfy any two major criteria or one major and two minor criteria, along with the etiological factors, along with elevation of BNP or NT-proBNP, along with the treatment of IV diuretics, especially in acute and chronic conditions. To diagnose those heart failures, either acute or acute and chronic conditions, you need to follow all these steps. You need to identify the signs and symptoms as a two major criteria, or one from major criteria and two from minor criteria, along with the elevated BNP or NT-proBNP, then along with the IV diuretic therapy. In that cases only, your acute heart failures or acute and chronic heart failures coding is going to be approved. Otherwise, it's going to be denied. Then what's the need of BNP and elevated of BNP and the NT-proBNP is to differentiate these signs and symptoms like a dyspnea and all from cardiogenic to non-cardiogenic reasons. If BNP is elevated or NT-proBNP is elevated, it is a cardiogenic. If BNP is and proBNP normal, and if patient having those signs and symptoms also, and your code is going to be denied if you be diagnosed based on this signs and symptoms. Then again, when it comes to the validation part, already we discussed it, right? You need to identify the underlying causes of heart failure, including myocardial infarction, any structural changes in heart and any coronary artery diseases and all. You need to identify, assess other comorbidities that may explain the heart failure signs and symptoms. That means these signs and symptoms, what we discussed, this can be shared signs and symptomatology by many other conditions. You need to identify there is no other condition which was sharing this symptomatology. That means patient should not have respiratory complaints that can share this particular symptomatology. Even though if it is a patient having suppose assume a respiratory failure and heart failure both have symptomatology should be very similar. Then in that cases, your BNP is going to be differentiate either that patient having heart failure or not. If BNP is elevated, then patient having heart failure, cardiogenic reasons. That was the most commonest cause of heart failure. Then another condition to identify that heart failure, BNP elevated, then to label the patient as a heart failure, you need to follow Framingham criteria 1 and 2. Two major criteria and 1+2, 1 major and 2 minor criteria, along with the Lasix therapy. then only you are going to, your code is or your claim is going to be approved. Then you need to identify all the signs and symptoms based according to Framingham criteria. Then diagnostic workups, you need to look for all these things, mainly cardiac markers like a BNP, NT-proBNPs. Then imaging findings like a chest X-ray and CT chest. There should be alveolar edema or pleural effusions or cardiomegaly and all. Then when it comes to the why this cardiomegaly and pleural effusions, and the signs and symptoms of cardiomegaly, we'll go to the previous slide. Suppose assume patient having a cardiomegaly and again bilateral ankle edema, hepatomegaly and pleural effusions. There is one major criteria and three minor criteria. Though they have satisfied with this particular criteria, if patient not having a cardiac biomarkers like a BNP or elevated BNP, NT-proBNP, along with IV Lasix therapy, those acute and chronic acute conditions are going to be denied, because once the cardiomegaly happened, it will be remain for, in some patients it may be remain for longer periods. Then even ankle edema also. Ankle edema can be caused by many other conditions. Even cardiomegaly can cause by many other conditions. That's why you need to have a BNP and Lasix. They make it as a parameter for diagnosis of acute heart failure, either elevation of BNP plus IV diuretic therapy. I think you get my point. Then BNP, why BNP need to be interpreted? BNP always should be compared with an already baseline BNP levels. Some patients BNP was elevated. Usually in records they used to say greater than 100 is a significant, but greater than 100 with the help of only greater than 100, very rarely heart failure is going to be approved. Very rarely, not as frequently. Then role of BNP, NT-proBNP. BNP is nothing but it's a protein, a type of protein which is going to be released by heart muscle when it was under deprived of oxygenation and some other injuries. Generally, even BNP is elevated in heart, not only heart failure, even some cardiac diseases and some non-cardiac conditions also. We'll try to interpret it. Then it helps to differentiate the cardiac and non-cardiac causes of dyspnea. Then again, useful when symptoms are vague and multiple comorbidities exist in the particular case. Then always compare with the patient's baseline. Suppose previously patient underwent BNP levels, those were already it's in a more than 100, means it's a near to 100, elevated but near to 100. Now also it was in a similar values. In that case, we may not say that the patient having acute conditions of heart failure, either acute and chronic. We may not supposed to say, because you need to compare the BNP values with the baseline BNP value. If it is grossly elevated, then only we need to say, argue that the patient having an acute forms of heart failure. This is the one area where appeal writers can use it. Then in denial sections. Then again, cardiac conditions that elevate the BNP are like in a first on heart failure, then diastolic dysfunctions, then again acute coronary syndromes, then hypertension with left ventricular hypertrophy, then valvular heart diseases and atrial fibrillation. The commonest causes are, these are the commonest cardiac causes for elevation of the heart failure. This one, BNP. So another non-cardiac reasons are advanced age of the person, including female sex. Female patients having more BNP in older ages. Then pulmonary embolisms, then pulmonary hypertension, sepsis, COPD, hypothyroidism, both acute and chronic kidney diseases. These are the areas where BNP is going to be elevated. Either it may be cardiac or non-cardiac or physiological. in advanced age in females. So that's why you need to segregate the signs and symptoms along with the BNP. Then along with the Lasix IV diuretic therapy, then only you can formulate the acute or acute and chronic forms of heart failure. Either it may be systole, diastole. The steps you need to follow to appropriately validate the heart failure. Then when it comes to the diagnosis part, key elements to confirm the heart failure diagnosis is like a symptoms consistent with heart failure, like a dyspnea, orthopnea, fatigue, congestion, and all. Whatever we discussed in the previous slides. Then presence of etiological factors. Then objective evidence of the diagnostics, like labs, BNP and pro-BNP has to be elevated. Then imagings, like either patient should have alveolar edema, cardiomegaly, and this is fine in echocardiogram. In echo, like a patient should have systolic or diastolic dysfunctions of the ventricles, along with the EFs and valvular abnormalities. If there are any things, you need to identify. Then BNP and anti-pro-BNP interpretation we did already to identify cardiac or non-cardiogenic reasons of the dyspneas and all. It must be interpreted relative to the baselines, then recognize both cardiac and non-cardiac causes of elevations. We need to identify the other reasons. If non-cardiac, like non-heart failure reasons was there for elevation of BNP, we are not supposed to blindly argue that since BNP was elevated, the patient having heart failure. Then holistic review of validation is correlate with signs and symptoms, examination findings, comorbidities, and diagnostics. Then ensure documentation supports acute, chronic, or acute and chronic heart failures. Physician has to document. Otherwise, it's our duty to raise a query form. Then again, ensure type of heart failure, either systolic, diastolic, or combined with an echocardiogram. Then confirm consistency across the provider notes, labs, imagings, and treatment plan. Like you need to follow all 7 high quality clinical criteria, clinical documentation criteria, like what we discussed in previous. If any parameter is missing, it's better to raise a query in spite of coding directly. Then we'll try to see some coding guidance. Presumed causal relationship. When we need to take it as a presumed causal relationship, even though physician was not documented. Then ICD-10 assumes a cause and effect relationship between hypertension and heart involvement, hypertension and kidney involvement. Then this is based on the term width in alphabetic index. Then code these conditions as related even without explicit provider linkage between these two conditions. If heart failure is physician documented it as due to some other reason, we are not supposed to select a code from hypertensive heart diseases category. Then when provider linkage is required, if the condition is not connected to hypertension by terms such as with, associated with, due to. Then we raise a query to the physician. If there is no significant etiological factors identified, like like a poisonings, like a valvular diseases, like any other reasons, if we didn't identify it in the medical record, it's our duty to raise a query to the physician to identify the etiology of the heart failure. Since it having an instructional note at I-50 category level, use first underlying condition, code first underlying condition. So we need to identify underlying condition first, then only we need to assign I-50 code. Then hypertension with heart diseases, I think we discussed this in previous slides. Then hypertension and chronic kidney diseases, when to use, this also discussed, I think. This also discussed. Coding and clinical concepts of heart failure. Then congestive heart failure is included within systolic and diastolic heart failure codes. Like if documentation list, we need to assign appropriate code, like either it is a systolic heart failure or diastolic heart failure. You need not to raise a query again. Somewhere, like a physician documented at CHF, then in other places of physician documented, like at systolic dysfunction or diastolic dysfunction, or systolic heart failure or diastolic heart failure. We can directly code it as a systolic or diastolic heart failure based on the documentation. If CHF documented without further specification, then we need to assign code from I50.9 heart failure unspecified. Then compensated versus decompensated heart failures are when heart uses compensatory mechanism to maintain say near normal functions, then where the cardiac hypertrophies that leads to cardiac hypertrophy, increased arterial pressures, ventricular dilation, and decreased contractile force, then symptoms may be stable and control. Heart itself having a mechanism of compensation and decompensation based on the requirements of heart, based on the function of the heart. This heart itself, it modifies. That leads to this particular like in a science. Those can be identified on both imaging and physical examination part. Then decompensated and exacerbation of the heart failure can be, you can identify like where compensatory mechanism fails. This decompensatory or exacerbates will come. Then it usually represents a flare-up of chronic heart failures. Then usually whenever physician documented say exacerbations, flare-ups and all are decompensated, we need to code it as an acute and chronic heart failures based on either systolic or diastolic or combined. Then this is the common I50 category codes, where if you identify the code first heart failure complicating either underlying conditions, code first underlying conditions may be it's a common in ectopic or molar pregnancy time, then due to hypertension with chronic kidney diseases, due to following any surgery, then obstetric surgery or procedures, then rheumatic heart failures. Rheumatic heart failures nowadays is becoming common in US healthcare. You need to identify appropriately a rheumatic valvular diseases any specified. You need to assign I09.81 first, followed by I50 category code. Then usually this I50 category was classified further categorized into I51.9 left ventricular failure unspecified, then systolic heart failure I50.2, I50.3 diastolic heart failure, I50.4 as a combined systolic and diastolic heart failures, I50.8 other heart failures, I50.9 as a heart failure unspecified. We discussed that whenever physician documented heart failure or CHF, he didn't specify whether it is in a right or left, either systolic, diastolic, or combined. Then only we need to code I50.9. We'll see left heart failure. Left heart failure is nothing but left ventricular failure. It will be coded to I50.1. When we need to code I50.1 is an important here. These are the inclusion terminologies like in a cardiac asthma, edema of lung diseases, edema of lung with heart failure, left heart failure, pulmonary edema with heart diseases, pulmonary edema with heart failure. These are the commonest inclusion terms where physician not specified anything, but it's related to left ventricular failure. We are going to code it as a left ventricular failure unspecified. That means physician is not specifying either it is an systolic or diastolic or combined. And even though you don't have any evidence in echocardiography, or echocardiography report is not available to take a decision whether it is a systolic, diastolic, or combined. In that cases, you need to code from I50.1. And when it comes to systolic heart failures, then you need to etiological factors might be common identify the description of the left ventricle, they will specify, physician usually specifies systolic dysfunction. EF is less than 40. Then only you need to code them systolic heart failure, and we don't have any code for mildly reduced or moderately reduced systolic ejection fraction heart failures. So those are also need to be coded under this particular systolic heart failure only. That means any heart failure is with an ejection fraction of less than 49 or equal to 49. If physician is not documented as a systolic heart failure in anywhere in the medical record, in spite of documenting or in spite of coding I50.9, it's better to raise a systolic heart query for systolic heart failure, either to confirm acute systolic heart failure or chronic systolic heart failure or acute and chronic systolic heart failure based on the symptomatology and BNP levels and diuretic therapy levels. Either if you given IV diuretics, better to raise for either acute and chronic heart failures. If oral diuretics was given, go for within a chronic heart failure query, chronic systolic heart failures. Okay. Then there is a codes. If you observe I50.2 category here, there is one code excludes one, like combined systolic and diastolic heart failure is an excludes one mode, because there is a separate code for combined systolic and diastolic. Hence, we are not supposed to code it here. Then again, there is an unspecified systolic heart failure, I50.20, I50.21 acute systolic heart failure, I50.22 chronic systolic heart failure, I50.23 acute and chronic systolic heart failure. If medical records is evident for elevated BNP or elevated pro-BNP, and medical records satisfying your criteria, like two major criteria, and either two major criteria or one from major criteria and two from minor criteria in according to Framingham criteria, and patient received IV diuretics, then it's a time to raise a query for acute systolic heart failure or acute and chronic systolic heart failure. If a patient having a history of heart failure, history of CHF, now the symptomatology looks to be an acute condition, then you need to raise a query for acute systolic heart failure. If symptomatology is not looks like an acute, or patient not received IV diuretics, patient received only oral diuretics, it's better to go with chronic systolic heart failure. If these parameters are you are unable to identify these parameters, but physician somewhere he specified a systolic heart failure, you are unable to identify the acute, either acute or chronic or acute and chronic, then only we need to go for I50.20 unspecified systolic heart failure. The next category is I50.3. Subcategory is I50.3, which is diastolic heart failure. That means like a left ventricle is unable to relax to collect the appropriate amount of blood, where ejection fraction is normal, contractile function is normal. That means it's going to be physician might document either it is a preserved ejection fraction. Then you need to identify the factors like echocardiogram should be a documentation of diastolic dysfunction. EF is identifying EF is not going to help here. Patient may identify more than EF is more than 50 means patient may have heart failure or may not have heart failure. Then echocardiogram left ventricular description is going to help you identify either the patient having diastolic dysfunction that leads to diastolic heart failure. Documentation of diastolic heart failure. If they didn't specify EF is normal, they didn't specify, then it should be not be a heart failure case. Okay. Then these are the same what we discussed in acute systolic heart failure. Either you need to identify whether it is an acute and chronic, or chronic. If are unable to identify all these things, then better to go with unspecified diastolic heart failure in spite of coding I50.9. The next is combined heart failure. In the same way what we discussed, patient left ventricle was having both impairments like systolic and diastolic impairments. Then you need to, it's the easy way to identify by ejection fraction and left ventricular descriptions. Ejection fraction will be less than 50. Either it may be mildly reduced or moderately reduced, either it may be severe reduction. And along with, there will be a documentation of left ventricular diastolic dysfunction. These cases leads to be combined systolic and diastolic heart failures. Then in the same way, like what we discussed previously, previous slides, you are unable to identify the it is an based on signs and symptomatology. If it is an acute nature, if physician not documented, better to raise a query. If patient having his previous history of CHF, then go for query of acute and chronic heart failure. If patient does not have history of CHF, this is the first episode, go with a query for acute combined systolic and diastolic heart failures. Then right heart failure, when it comes to the right heart failure, then most of the times right heart failure results from the left heart failures. Then results from failure of the right ventricle to pump blood effectively into the pulmonary circulation. It leads to systemic venous congestion rather than pulmonary congestion. Common causes include left-sided heart failure, pulmonary hypertension, chronic lung diseases, then pulmonary embolisms, right ventricular infarctions, then valvular diseases like tricuspid and pulmonary valvular disorders. When it comes to the coding part, this I50.81 was classified into, again, like whatever we had seen in left ventricular failures, like acute right heart failure, chronic right heart failure, acute and chronic right heart failure. Then right heart failure due to left heart failure and biventricular heart failure. Here there is a tricky point we need to remember. Suppose physician documented acute systolic right heart failure, then we need to code acute right heart failure and acute systolic heart failure from I50.2 category, subcategory. That means without left heart failure, this patients may not be developed right heart failure. That was the concept behind the coding guideline. Then right heart failure typical clinical findings include jugular venous distension, hepatomegaly, ascites, and peripheral edema, weight gain from fluid retention, and abnormal discomfort. Or fatigue and weakness. Then documentation requirements are patient should specify the type of heart failure, like a right-sided, and in that again acute, chronic, or an acute and chronic. Then identify the underlying causes like a COPD, hypertension, left-sided heart failure and all. Then document associated findings, like associated findings and supporting right-sided heart failures. Then JVD and all you need to identify. Even in echocardiogram also they will specify that description of the right ventricle and all. You need to identify all these parameters and code it appropriately. Generally, when a right heart failure is documented, these findings may be present in the medical record. You need not to worry about right heart failure. Generally, only if you concentrate on left heart failure, you can easily understand the left heart failure and you can handle easily coding operations. Clarify if right-sided heart failure is either secondary to left heart failure or due to car pulmonary. The released raise related to pulmonary diseases and you need to ensure consistency across the progress notes, imaging, labs, and treatment plan. Then when it comes to coding clinics, then 2023 Q3 suggests assign a diastolic heart failure from I50.3 subcategory for both heart failures with recovered and recovered ejection fraction and heart failure with improved heart failure, improved ejection fraction. Generally what happens in cases previously patient having a reduced ejection fraction, that means having systolic heart failure. Generally this type of cases will come after interventions like a TAVR, aortic valve replacement, and cardiac remodeling therapies, ventricular remodeling therapies. After this therapist, patients will going to improve ejection fraction from less than 35, 40 to 49, less than 49 to patient may improve more. It reaches to greater than 50, then those cases has to be coded as a diastolic heart failure only. Though previously having a systolic heart failure, since at current scenario patient recovered his ejection fraction, still heart failure is there, then we need to code it as a diastolic heart failure. Then 2025 Q2 suggests to assign I-17 97.89 for heart failures which was developed after a surgery, any cardiac procedures or non-cardiac procedures. Especially heart failures are common in after the during the cardioversion procedures, electrical cardioversion procedures. Some patients may landed into heart failure. Those procedures is not supposed to be coded from, those services are not supposed to be coded from I-50, I-11, like in a hypertensive related heart diseases. Okay, you need to code it as in a post-operative heart failure from I-97.89 subcategory code, then followed by either it is a systolic, diastolic, and its a specificity. You need to follow the same guideline. Then again, 2020 Q4 suggests assignment of codes from I-50.2 for heart failures with mid-range or mildly reduced ejection fractions. Then 2020 Q4 suggests assign a code from I-50.3, like what we discussed just now, where ejection fraction was improved after TAVR, transcatheter aortic valve replacements. These are the from procedures from coding clinics, like a precardia placements. What is a precardia? Precardia is a device for an acute decompensated heart failure, treatment of acute decompensated heart failure. It uses an intermittent SVC occlusion via balloon catheter to reduce the venous return. Then again, it aims to improve the cardiac output and prevents the volume overload. How they are going to perform this precardia placement is they will insert a Schwann-Ganj catheter into the distal pulmonary artery for hemodynamic measurements and all. Then they will insert the precardia balloon catheter into the superior vena cava to occlude that particular superior vena cava. Then when it comes to the route, like in ICD-10 PCS codes, usually it has to be coded from the assistance route operation because the device supports the cardiac output. That means it's reducing the venous return and improving the cardiac function. So we need to code it from the occlusion. We need to code it from the assistance. Though the procedure is going to be occluded. They're going to be occluded the superior vena cava. But the intention of the procedure is to assist the cardiac output. That's why we need to code from assistance route operation. Then code will be like a procedure code will be 58021110, like an assistance with a cardiac output using a balloon pump intermittent. Then when it comes to the CPD physician coding, then they like a 33999 and 93503 should be used for precardia placement. Usually there is no specific CPT code for precardia placement. Then we need to code it as an unlisted procedures. Then next one is an AccuClean. Then it's in a procedure. How they are going to do the procedure is they wire advanced across the aortic valve into the LV cavity. Then it's deliver a sheath positioned beneath the mitral annulus. Then a track catheter placed around the annulus, and the device is deployed, resulting in reduced mitral regurgitations. Especially whenever there is a severe mitral regurgitation, what happens? That the blood which enters from the left atrium to left ventricle, it is going to be regurgitated. That means it's coming back from some of the blood volume is going to be coming back into the left atrium again. To avoid that, this device is going to be deployed under the mitral valve. Then the root operation has to be coded as a restriction. That means whatever the function of that particular valve is going to be improved by restricting the what is that mitral valve. So hence we need to code it as a restriction root operations. Then it has to be coded as a restriction of left ventricle with an intrapulmonary intraluminal device. We need to select from 0 to VL3DZ. Then syncardia. This is another device. It is a biventricular total artificial heart used for patients with an end-stage heart failure. Here, by deploying this particular syncardia, physician is going to be like replacing the entire heart, like both right ventricle and left ventricles. So we need to code it as a replacement. If you read the device objective itself, it's a biventricular total artificial heart used for patients with an end-stage heart failures. Then it replaces both ventricles and all 4 native valves. And used as a bridge therapy, like to transplant cases, or it can be used as it provides full cardiac output when both ventricles fails. Indications are like an end-stage biventricular failure or cardiogenic shock or end-stage heart failures. Then syncardia is a total heart, artificial heart replaces the native heart. Then it meets the root operation definition of replacement. So you need to code it as a replacement of right ventricle, replacement of left ventricle. For removal, then this code, we need to code it as a 02PA0RZ, like in a removal of external heart system from heart, open approach. Then when it comes to the physician billing, for insertion, we need to use 33927, like implantation of total replacement of heart system. Then for removal, 33928, a removal of total replacement heart system. For revisions, reposition and repairs, we need to code 33929, like a reposition of total artificial heart system. For monitoring purpose, we need to code it as a 93750. Then another device is commonly used in inpatient settings is impella placement. There's a coding clinic related to this impella. Then impella is a percutaneous ventricular assist device. Then it's an external heart system. Then temporarily supports the left ventricle or right ventricle based on the requirement. Then it helps to maintain the cardiac output in patients with severe microaxial pump inserted via the femoral or axillary artery. Then it draws blood from the ventricle and expels it into the aorta to support the left ventricle. In terms of left, if implanted in right ventricle, it's going to collect the blood from the left ventricle and eject into the pulmonary circulation. There is 3 types of impellas, like a 2.5 CP or 5.5 and 5.0 and 5.5. Then impella or like an impella RPL for right ventricular support. Then usually a documentation purpose, you need to identify for medical to approve the medical necessity. Like a patient should have, physician has to document in the operative report which type of impella is going to be implantation. Then clinical indicators has to be documented, either the patient having cardiogenic shock or high risk PCIs, or acute MI with LV failures, or acute decompensated heart failures, or RV failures. Something he has to document according to the case. Then you need to identify blood pressure trends, cardiac output index, and lactate levels and all prior to the surgery. Then response therapy is after putting this impella, like either patient improved perfusion. During the procedure itself, they will identify it and document it. Reduced vasopressors requirements are. Then again, Duration and management, you need to document, you need to identify date and time of the insertion and removal of the impellers. Then when it comes to the coding part, then impeller is coded based on the device type, approach, and ventricle supported, either left ventricle or right ventricle supported. Based on that, we need to code it as. Impeller is not coded as an LVAD. LVAD is nothing but left ventricular assist device. Impeller is different and LVAD is different. It is a short-term external assist device, impeller. Then document type, indicate type of that impeller, then indications, approach, and ventricle supported. You need to identify to find an appropriate character levels, like at second, third, fourth characters. Then PCS uses the device value as an external heart system for impeller. Then it's for inpatient clients, PCS codes drive DRG assignment of like a 215 and 216. Then left ventricular impeller placement. These are the codes. Like you need to code from 0 to HA3RJ for a short-term external heart system into the heart percutaneous approach. Then it's in a fifth character 4 explains in a percutaneous endoscopic approach. Fifth character 0 explains either the inserted or under open procedure. Then for removal, again you need to use these two codes, like in a 02 PA3RJ for removal of impeller from left ventricle percutaneous. Then 02 PR3RZ for removal of impeller percutaneous approach. Then when it comes to the physician coding, these codes need to be used. It has to be coded under percutaneous ventricular assist device. For insertion, we need to use 33990 and 33995 for left and rights. Then removal, again 33992 and 33997. Then repositioning is 33993. Then you need to, when there is a high risk PCIs, then you need to code your add-on code from 92978. That's it for today's session. Any questions?
Yeah, Hari, thank you for this session. There are few questions in the chat box. Okay. Hari, am I audible?
Yes, yes.
Okay. In the chat box. Meanwhile, we will address the questions which we received during the session. Okay. So the first question is on, there is an argument in coding of heart failure with recurred ejection fracture as diastolic heart failure or chronic diastolic heart failure. What is the guidance we will follow as per AHA?
You need to use the Framingham criteria here. Whatever it may be, recovered or reduced. The question is related to reduced, right?
Yes. Yes, Hari. Yeah.
Whenever there is a reduced ejection fraction, see, we discussed right while coding the support, like there is it has to be coded from I50.2 subcategory. Then I50.2 is classified further into I50.20 systolic heart failure unspecified. I50.21 is an acute systolic heart failure. I50.22 is a chronic systolic heart failure. I50.23 is an acute and chronic systolic heart failure. Whatever the concept we are going to discuss is applied for all categories, I50.2, I50.3, I50.4. See, you need to identify the signs and symptoms, basically. Either BNP elevated or BNP not elevated, it's not a matter here. Since physician documented as a heart failure, that means we need to proceed with the coding of heart failure. Then you need to identify signs and symptoms. If patient satisfied major criteria, 2 major criteria, or 1 major plus 2 minor criteria, you need to find it from the Framingham criteria. Then you need to address either the patient received oral Lasix or oral diuretics or IV diuretics. If patient received IV diuretics, you can code it as an acute form of heart failure. Then either it may be acute heart failure or acute and chronic heart failure. Then when should be acute and chronic heart failure? Physician used to document as a history of CHF. Physician documented it as a history of CHF at somewhere else in the entire medical record, and patient having satisfied either two major criteria or 1 plus 2 minor criteria, then received IV diuretics. Then you can go with an acute and chronic heart failure, systolic heart failure. Suppose if criteria is not matching and if patient does not receive IV diuretics, it's better to go with chronic systolic heart failure. The same concept will apply to all three types, even for right heart failure also.
Okay. Thank you, Hari. I hope Daroga it clarifies your question. Do you need any additional clarifications here? Okay. There is another question, Hari. That is, provider documented heart failure. In the same question we received from Dagora as well. Okay. So during the presentation, Hari, am I audible, Hari? Hello.
Yes.
Okay. See, the clarification is majority of the questions we have received what to consider for recovered ejection fracture versus improved ejection fracture. So during the presentation, we have explained that if the ejection fraction is less than 50 of heart failure with recovered ejection fracture, it should be considered as systolic heart failure, and ejection fraction there is a confusion here
Okay.
in this topic. So
Suppose
could you
the
please
physician
explain that?
documented either it is an improved heart failure with improved ejection fraction or heart failure with recovered ejection fraction. It has to be coded as a diastolic heart failure only.
Okay, got you. This is clear answer we received. I hope the group is clear with this now. And there is one more question. What is the normal ejection fracture we have to consider?
Normal ejection fraction is greater than 50. Generally, when healthy people, their ejection fraction is greater than 55. Ejection fraction is not in a measurement, it's in a comparative measurement. Like it's not an exact measurement, it's a comparative measurement. It's based on the physician's experience, like a echo sonographer or echocardiographer who are taking either a cardiologist or whoever it may be. It's depending on their experience, and based on their experience they will give a value. It's not going to be a fixed measurement. Once it was documented like in a low rejection fraction, so one physician may give it as a high ejection fraction also for the same case. It's in the next day itself, because it's in a physicians. There is a difference between their experience, whatever they feel while doing that heart echocardiogram, they will give it as an ejection fraction. That's why you need to correlate with ejection fraction along with the LV dysfunction, either systolic dysfunction or diastolic dysfunction. They used to document in the medical record, echo report. Then you need to correlate with the EF. If it is a systolic heart failure, then that should be less than 50. If it is a diastolic dysfunction, EF should be greater than 50. There's only the demarcation point.
Oh, okay, Hari, got it. But there are few more questions, so we will do one thing. I will share the ejection fraction related questions to you, so we can include one more slide to explain that in detail, and we will share it with this group.
Okay.
Okay. And there is another question related to diastolic dysfunction. That is, can we correlate both diastolic dysfunction mentioned in assessment and heart failure mentioned in past medical history? So here in outpatient setting, we will go based on the physician assessment, what is documented by the in the assessment, we will go with it. So what we will consider for IP, Hari?
Okay. Generally, outpatient settings and outpatient billings, coding and all, there is no concept of CC, MCC because it's not any, they're paying according to either APG or EAPG systems in US healthcare, other fee for service methods. When it comes to this system, they are like an ICD-10 is not a parameter for payment. CPT code is a parameter for payment. So when it comes to in outpatient settings, even you coded it as a either systolic or diastolic, it is not going to impact your payment. But when it comes to the quality, it's a continuation of care and quality. That quality of the documentation. Nowadays, even CDA also expanding to the outpatient facilities. So the same guidelines you need to follow in outpatient settings also. That when it comes to the inpatient settings, the payment unit is DRG. So there also, if it is an acute or chronic having a matter, they're going to impact the payment. Are not based on the quality of the heart failure, either it is systolic, diastolic, and all. But only the matter is like a quality documentation and inpatient quality measure is going to impact. Those measures are going to be impact, not payment also based on systolic or diastolic. Only like in hospital quality measurements are going to be impaired or impacted. But if a hospital quality documentation quality measures impaired or no impacted, no, this impact is going to be appear in the next year to assign a base payment value. Usually, how DRG payment comes to a hospital is based on the coding, the quality of documentation based on the coding. They are going to assign in a quality ratings. Like suppose if you take Leapfrog and some other OIZ, some other organizations was there. They are going to give a ratings 1 star, 2 star, 3 star ratings to each and every hospital in US healthcare. Okay, yeah, based on those star ratings, hospitals' base payment is going to be decided. That means based on your quality of documentation, what type of treatment you are going to provide to the patient. Based on this these parameters are going to impact your quality ratings. Then 2-star hospitals, some same DRG. DRG is okay. I will try to explain in this way. DRG is a parameters base unit. DRG having, if you see in a 3M or somewhere else while coding, DRG having a relative weight. This relative weight is going to be unique for entire US country. But locality having a 5-star rating, their base payment will be $10,000. Then hospital B in the same locality will be 3-star rating, their base payment value will be 8,000. Another hospital was there, their quality is very low, their base payment may be 4,000 or 5,000. Then how hospitals are going to expect their reimbursement is, this base payment rate is going to be multiplied with the relative weight. Suppose heart failure, acute heart failure, DRG is 291 or 292, 293 DRGs. Their weight may be like a 1.2934 or something. If hospital A is going to get a 10,000 into multiplied by 1.2934, then hospital 2 is going to be get by 8,000 into same 1.2984. Then hospital 3 is going to get some 5,000 into 1.2984. This 10,000, 8,000, 5,000 is going to be decided by the hospital performance in terms of treatment, in terms of documentation, in terms of denials. All these are going to be impact your hospital based payment. Whenever as a coder you perform your activities appropriately, and if you try to increase the quality of the hospital performance, indirectly you are going to impact the hospital payment by increasing the star rating. Once star rating is going to improve, then the base payment is going to increase. This base payment is going to be decided by the government, not by any private organization, not by any hospital itself. You understood, right?
Yes, yes, Hari. It is clear. You have explained based on how we follow, based on the US hospitals with base price and all. It is clear to us. Thank you, Hari. And there is one more question that is related to Impella. Okay. So, how to identify whether the patient is underwent Impella 2.5 or
Okay,
5.5?
in
Now,
operative
any
report,
tips?
physicians is
There is
going
a
to
question
be
from Dinesh here.
document it.
Hello.
Physicians in operative report, if they tell is going to implant it.
Okay. Got it. So they have to go based on the physician documentation. And there is one more question related to the confusion they had between diastolic dysfunction and diastolic heart failure. So can we consider diastolic dysfunction as diastolic heart failure?
No,
No.
that's why what we used to say in inpatient settings and clinical scenarios, heart failure is a clinical condition. We discussed, right? If you simply remember NYHA classification, though patient having asymptomatic states, there the patient having either systolic dysfunction or diastolic dysfunction, but patient does not have any signs and symptoms. So clinically patient is stable, asymptomatic. Those are
Got
supposed
you.
to be coded as a heart
Got you,
failure.
Hari.
That's
And
why
the last
Framingham
question
clinical
is
criteria
on
came into the
what
picture.
is
You
the
need to follow major and
sorry, Hari, to interrupt you, but your voice is breaking in between. So we
no,
will do one thing. We will do
Mm.
one thing. We will document all the queries what we received, and we will address those queries during the in the presentation, and we will share it with the group.
Okay.
Okay. And the last question, we will address this last question, and we can conclude the session. The last question is, what is the difference between heart failure and myocardial infarction?
Yes, it's a good question. Myocardial infarction is a due to ischemia. Otherwise, we can say something. Due to any abnormality in the circulation to the heart itself. Like usually, heart is a muscular organ, right? Heart muscle itself, it requires some oxygen or blood supply to conduct their function. So heart is going to be supplied by two main arteries, what we discussed, left coronary artery, right coronary artery. Again, left coronary artery is going to divide it into left circumflex artery, left anterior descending artery, and right coronary artery. These three are main arteries. Whenever there is a blockage or obstruction or occlusion in these particular three arteries, then blood may not reach to the distal parts of the heart, like a heart tissue which is supplied by the distal parts of the particular occlusion. Then there the heart muscle is going to be deprived of oxygen. Then it's going to be called as ischemia. If ischemia is disease is progressed and vessel is totally 100% occluded, there is no blood supply at all, then it is going to be infarction. It's nothing but cell death. Infarction is going to be, it's a layman terminology, it's a cell death. Okay. Then when it comes to the coding part in inpatient sectors and all, usually in myocardial infarctions, because of that particular ischemia or infarction, like blood supply, lack of blood supply, heart tissue is going to be release in a enzyme like in a marker called as cardiac troponin. Usually, even though it is released, this particular BNP also elevated in particular heart failure, in heart failure and myocardial infarction also. How to demarcate or differentiate between heart failure and this particular heart failure and myocardial infarction is, in cases of, if you take in a heart failure cases, if you review the echo report, physician will specify LV dysfunction or LV systolic dysfunction, diastolic dysfunction, or EF, and everything he will specify. And will be no documentation of abnormal movements of the myocardium. Then when it comes to the myocardial ischemia, there will be a finding, that's a wall motion abnormality. That wall motion abnormality is one of the indicator to go for angiogram. If you do angiogram, you can find out any occluded vessels or lesions and all. Then again, myocardial infarction, when it comes to the inpatient settings, myocardial infarction is going to be validated by fourth universal definition of myocardial infarction, where patient should have any cardiac elevated, like an elevated cardiac troponins. It's like a 99 percentile of elevation of cardiac troponins, and along with any one of the signs and symptoms of ischemia, like in a shortness of breath, chest pain, there are some certain signs and symptoms of ischemia. Any one of signs and symptoms should have. Again, all elevated troponins are not going to be defined as a criteria. Two subsequent values should have minimum difference of 20%. Like cardiac troponins has to be followed two patterns. Either troponin at the time of admission to this, like a time of discharge, the troponin has to be elevated. Each two values should have minimum of 20% difference. Otherwise, patient may admit after that totally patient was evolved into the myocardial infarction in advanced stages of myocardial infarction. Assume that at that time this troponin values has at peak levels. After receiving the treatment, it has to be decreased. That's why how myocardial infarction definition is defined by fourth universal definition is a 99% elevation or reduce in the cardiac troponins along with any one signs of ischemia. That is the classical definition of myocardial infarction. Myocardial infarction means heart muscle itself is deprived of oxygen due to any reasons, like common reason in blood vessels. Heart failure, it means heart is a fail to conduct its function. What is its function? It has to send the blood into the systemic circulation. So that activity is going to be failed due to any reasons. Myocardial infarction may be a one reason for heart failure, but both are different. Understood, right?
Yes, Hari. It is very clear with documentation example. So thank you, Hari, for the detailed explanation of clinical documentation and DRG coding for heart failure. This session was highly valuable for both the new and experienced coders working in inpatient and outpatient settings. Before we go with the vote of thanks, I would request Harish to address on the CEU thing. Harish, could you please address about the CEUs?
Yeah, thanks, Madhuri. Um, and thanks, Hari, for taking this session and sharing your insights on this topic, so that will be useful for our community. So again, good morning, everyone. So just wanted to take a couple of minutes explaining about the CEU thing. So there are so many questions about the October, November CEU thing, as well as some of the December. See, the December was so I have some pointers for you guys to note. The first thing is, first point, no one is asking your AAPC ID or email ID in the chat boxes. So please be aware of this, and don't put all your details into the chat boxes. So everyone can see that information, and those can be misused. Okay. So this will affect your privacy. So make sure that you are following this. So don't blindly put all those information into the chat boxes when no one is asking. First point. Second point, on the December CUs. So the December CUs, like 60% of the attendance has already been marked into AAPC. So there is a 40% that is balance. So since December event was very recent, so we usually take up to 3 to 4 weeks to complete your attendance. So the December event, so we don't have any issues. So once the remaining attendance is marked, uh, so you will get your CUs accordingly. So that is on the December CUs. Coming to the November and October CUs, as we mentioned previously in the AAPC chapter channel, as well as in the LinkedIn page, we did encounter some technical issue. So wherein even after marking your attendance, we can see that some of you have not received your CU. So for that solution, we did work, with the AAPC team, and we did find a solution. So that is the reason why we have opened a form for you guys to fill in the details, especially for the people who have not received your CU. So we did receive around 499 or some 500 responses from the folks who mentioned that either they received, either they not received CU for October month or November month or both. So those details are with us now. So we closed the form. So everything is closed. So we received close to 500 entries there. So now the next step is within next week. Okay. So within next week. So for all of you guys, so we will be sending out a communication on how you can get the CUs. Okay. So make sure that you keep an eye on your mailbox in your AAPC or whatever the email ID that you have given in the form. So make sure that through that email, so keep an eye on your inbox. We will be soon sending out your instructions about how you will get your CUs. And one very, very important stuff I wanted to mention here. So the information that is mentioned is only the information that will be sent to you on how to get your CU for that particular month, especially for October and November, for whoever has not received so far. So make sure that that email is only catered to you, and you should not be sharing it across to your friends and all, because that will be tracked, and each person will have unique way of getting the CU. So if that is shared with anyone else, so AAPC will be tracked because that is a unique number, and AAPC will be able to track that if that is applied by someone else or shared by someone else. And whoever is shared and whoever is applied, and if there is any duplication and all those stuff, so that will be coming under purview of AAPC review. And you guys might be listening many things nowadays because of the CU misusage and all. So AAPC is canceling the certifications as well. So be careful, and these instructions will also be mentioned in the email. So make sure that you follow that and apply properly to get your CU for November and October month, or whoever has filled the forms. This is especially for you guys. So you will be receiving an email within a week on how to get your CU. So make sure that you follow those steps, and you'll get your CUs applied towards your account. Okay, I'll pause here, and maybe I'll leave it a minute. If you have any other questions, you can ask in the chat box.
So, guys,
I hope this
there is a clear
clarified.
instruction not to share your details here, but still we see the details are shared in the chat box.
So that was my first step. That was my first point. So no one is asking your CU. No one is asking your APC ID or email ID. This chart is visible to more than 3,000 plus people. So those details can be misused completely. Okay. So don't blindly put all your details into the chat box. We will ask if it is required. We never ask the details of AAPC ID or email ID into the chat box because we already have your details captured from the backend through your attendance and all. So don't put your details into the chat box.
Thank you,
This is
Harish.
not only for this
Like,
meeting, for any of the meetings that will happen in the future as well. Okay, so as I said, the December month CU, so the attendance is like 60% mark. There is a balance of 40% attendance that needs to be validated according to us. I mean, from our side only. So once that is done, whoever has attended and stayed 90% of the time into the session, so they will receive the CU accordingly. So there is a pending. I mean, there is an attendance marking pending that is there from our end for the December month. For November and October month, as I said, you will be receiving an email within a week. Okay, and where you will get an instructions of how you can get the CUs. So though that information is something that is pertaining only for you individually, or and that information should not be shared across. And someone is asking about the recording of this session. So this session will be uploaded into our AAPC chapter channel in YouTube. From there, you can view whatever the session, I mean, whatever the portion that you missed, or if you want to revise. Okay, so you can go to the AAPC Hyderabad local chapter YouTube channel. From there, you can view this. Hope this
thank
clarified everyone.
Yes, Harish. So they agreed to it and they're acknowledging your message regarding CUs and they did not share their details in the chat box. Thank you, Harish. Thank you for your you addressed about the CUs. And there is one request regarding podiatry coding session by Tanish. Sure, Tanish, we will plan the session on podiatric coding and we will give the dates when are we going to conduct the session. Noted. This is noted, Tanish. So regarding Harish, there are a few more concerns regarding this session CUs. Give us couple of weeks. We will mark the attendance and we will share the communication in our LinkedIn page once we are done with the attendance marking. You will receive the CUs for this session in couple of weeks. Okay. So if there are no questions, we will conclude the session with vote of thanks. I request Srinivas to give the vote of thanks for the speaker and the audience.
Hi, Madhuri. Morning, everyone. Thank you so much. So, on the behalf of APC Local Chapter Hyderabad, so I'd like to thank Speaker Harigaru. So, such a wonderful session, insightful, and there is, I would say, A to Z about the heart failure, which is wonderful. And so, I got some information which is absolutely new and very good. I think the attendants would have enjoyed and would have learned a lot of things. And I'd like to thank Adilakshmi ma'am. I'd like to thank Harish, Madhuri, and I'd like to thank Prasad, who is new into our the board. So guys, so this session definitely is very good for you and for the experienced people as well. And I once again thank Harish on the behalf of local chapter Hyderabad, Hari on the behalf of local chapter Hyderabad. So with that, there's one last thing that I want to mention, that Harish has given enough information and Madhuri has given enough information. The only thing I want to talk is so when you're filling your information, I'd like to request, this is a kind request to you, that give your details correctly. The member ID is very critical when we mark our attendance. So there are some IDs where we are facing some difficulties. So uh, that is very important. So I think that is what all we have. Uh, Thank you so much for your time. Happy weekend. Happy holidays. Happy Pongal in advance. Thank you, guys. Thank you, everyone.
Thank you all.
Thank you all. So we can conclude the session once again. Thank you for your time and happy learning to everyone.